would like to thank the College of Specialist in Rheumatology and Rehabilitation Sri Lanka for giving me this opportunity, and especially Usha Madam for dragging me out to do this presentation today. I'm going to discuss a case which I have come across during my work in District General Hospital, Ampara. As you all know, it is a very underprivileged area in Sri Lanka, Eastern Province as a whole, and Ampara district especially in that area. So my presentation outline will be, I'll be discussing the case, and I'll be discussing the challenges I have come across during the diagnosis and the management of that patient in the peripheral setup, and what happened to the patient, of course, obviously cause of the disease. So my patient is Mr. D. He is 38-year-old male from Siembalanduwa, further rural area. And he had a history of type 1 diabetes mellitus, diagnosed about 1 year ago, and was on insulin. He was actually referred to me from the ICU, medical ICU, and he had a above knee amputation of right lower limb. And because he had multiple lower limb ulcers and generally not getting better, he has been there for quite some time. By the time I have seen him, like 1 month. He had this above knee amputation because he had multiple ulcers which are not getting better, and he has diabetes as well. You all know when patient has diabetes and multiple lower limb ulcers, when they are trying to give loads of antibiotics and still not getting better, then comes the suspicion of necrotizing fasciitis, and also surgical team came in, and so he had a above knee amputation. And still he is not recovering. So to share the burden, actually anesthetist referred to the patient to me. So in history, he had constitutional symptoms with significant loss of weight for 1 year. Like he has fatigue, malaise, loss of weight, loss of appetite, and he's so in peripheral setup, he's been investigated, and tuberculosis was excluded, and he was on work for the to rule out malignancy. While on investigating for all those things, he developed bilateral lower limb ulcers. With that and poorly controlled blood sugars, he admitted to the Ampara hospital, and then he was managed as sepsis. At that time he needed multiple inotropes as well. Because of the suspicion of necrotizing fasciitis, because ulcers are not getting better with antibiotics, he had a right above knee amputation. While he had right above knee amputation, he also had left leg ulcers as well, and this continued to spread. That is where rheumatology came in, and still he was on multiple antibiotics. So examination, I have put only positive findings here, rest are negative actually. So he was cachectic, pale patient with multiple lower limb ulcers, and he had right leg above knee amputation. And upper limb also, he had several lesions. I'll show you the pictures, and his blood pressure was stable without inotropes at that time. So this is how his legs look like. Actually, these photos were taken when he recovered a bit, actually. Very first stage, I don't have pictures. So he had very angry looking ulcers, especially at the edges, with necrosis at the center. So these ulcers spreading from foot to up just below the knee level. Actually, those are not in the posterior aspect, but mainly over the shin area. And upper limbs, he had ulcer where he had a cannula before, and where he had vena punctures. And this is the picture. He had a cannula on the other forearm before, and they have been given noradrenaline from that cannula, and that is a little bit of dysfunctional, and then he developed the latest rash as well. So what would be the next question? Obviously, this is just one simple look. You see cannula site ulcers and vena puncture site ulcers. So what came to my mind was, I have asked two questions only. Does the patient has oral ulcers and scrotal ulcers, and if they are recurrent? All the questions, the answer is yes. So, but there was no ophthalmic manifestation. This is the scrotal ulcer. Actually, again, that was recovering one. He had a very big one, and he has never come up with that thing in the history. He never told that to a caring clinician before, and no one has asked that either. So my clinical diagnosis by that time, it's straightforward, Behcet's disease. And have I done the correct diagnosis there? So this is international study group diagnostic criteria for Behcet's disease. So they has to have recurrent oral ulceration plus or minus two other things. So he had genital ulceration definitely, and skin lesions. Even though he doesn't have erythema nodosum, but what he had like pyoderma gangrenosum like lesions. And obviously his pathology test, we didn't need to do that. It was positive. He had an ulcerating pathology reaction there. So investigation summary, ESR was 95, CRP is 55, and he had anemia, which is a little bit of iron deficient features as well. And UFR, he had albuminuria, which was 3+, and that has been there quite 6 months ago as well. And again, he's never been seen by a nephrologist or considered renal biopsy before. But creatinine was normal. Liver function test, he had mild transaminitis with low albumin and marginally elevated globulin. Probably is a systemic inflammation and reactive hyperglobulinemia. And chest X-ray, there is a little bit of opacity on the right upper zone. 2D echo he had before actually. He had pericardial effusion and left ventricle diastolic dysfunction with ejection fraction of 30%. Ultrasound scan was normal. These are the investigation he had by the time I seen him. And lower limb arterial duplex, it suggested query diffuse PVD, but no, he had normal flow throughout. So at this point, he has, in addition to necrotic ulcers, he has definitely serositis and 3+ proteinuria, probably nephrotic range. So in that point, after seeing the investigation, I had several other differentials as well. Behcet still come up first, and systemic lupus erythematosus, and small vessel vasculitis, if this is GPA, with the presence of chest X, probably granulomatous chest X-ray and proteinuria and rash of vasculitis as well. And PAN, again pyoderma-like lesion, or if this is paraneoplastic manifestation of the ulcers, if this is paraneoplastic manifestation of the hidden cancer. So keeping in those in mind, I have planned this investigation, ANA, DSDNA, complement levels, ANCAS with PR3 and MPO levels, ultrasound scan abdomen with renal artery Doppler, skin biopsy, renal biopsy, and eye referral to rule out ocular manifestations of Behcet's or ocular retinal vasculitis, and CT angiogram of the left limb. That is because surgical team every time coming in, his ulcers are not getting better. So it's like he's going to have amputation on other leg as well. So CT angiogram of the other leg, and CECT chest to evaluate that lung opacity in the lung. So in a peripheral setting, what we could do, I know where I've been trained, I could have done all these investigation probably, but in Ampara, you don't have the luxury of having all those investigations, sophisticated investigation for you. Somehow patient did a ANA that became positive. DSDNA I couldn't do. C3, C4 level again was not available. ANCA not available. And from what we could do, he had nephrotic range proteinuria and urine PCR. An ultrasound scan of the abdominal renal artery Doppler was normal. Eye referral, no ocular Behcet's were seen. And a CT angiogram, these investigations came later somehow. So CT angiogram of the left lower limb, there were no arterial occlusion or evidence of large vessel vasculitis. CECT chest. By the time he had CECT chest, just before that CECT chest, he had another chest X-ray, and that lesion has disappeared. Only they have noticed bilateral pleural effusion with pericardial effusion and no other abnormalities. Medical team somehow convinced to do procalcitonin level, because when I suggested we need to pulse him with steroids, they were scared because they have been treating throughout, they have been treating for infection. So they have done procalcitonin, so they can be convinced to give steroids. Luckily, it was negative. So how we manage? We kept the actually diagnosis open because that is SL is still high up in the list, and small vessel vasculitis is still high up in the list. But from the clinical diagnosis is Behcet, so I still kept the diagnosis open till at least other investigations are available, or until we can do them, and started on treatment. So he was started on IV methylprednisolone 500 milligrams daily for 3 days, and followed by oral prednisolone. He was cachectic and only 40 milligrams of weight, so 40 milligrams per day. And azathioprine I couldn't start at the beginning because he had a little bit of transaminitis, ALTs in 100, and colchicine as well for cutaneous Behcets, mucocutaneous Behcets. So he had good response to steroids. Those ulcers became little bit better. I mean, they were very angry looking at the beginning, but that angry look was coming down. But when nephrologist came into board, we had to stop steroids for 2 days. That is, after 2 doses of methylprednisolone. And by the second day, again his ulcers started to get worse. So he was restarted steroid just after renal biopsy. So that is how we managed actually. To continue steroids, we had a bit of trouble to continue steroids, and whenever that ulcer is getting worse, not thinking about it is because of stopping steroids. Surgical team, because they have seen the patient every day, because he had an amputated leg. So again, they were planning to take him to the theatre for wound dressing. I&D and wound dressing, everything. So I have to keep surgical team. I had to keep surgical team away. So I continued steroids and showed them this is getting better with steroids. And after a while, caring physician again, because I haven't named the disease, I haven't given the diagnosis. We haven't given the diagnosis. Because of that, he was planning for a bone marrow biopsy. Obviously, when planning for a bone marrow biopsy, hematologist reaction is stop steroids at least for 2 weeks, and then they will do the bone marrow biopsy. So at that point, I made my mind, and then I labeled the thing as Behcet's disease, so no one can argue. So is the story over? Patient actually made partial recovery of all ulcers, upper limb ulcers and lower limb ulcers, and his well-being was improved, his appetite regained, and he gained a little bit of weight as well, and he was weak after months of ICU stay. And inflammatory markers were coming down and off antibiotics, but he had grumbling blood sugar, obviously, with high dose of steroids. And he was taken over for rehabilitation later on for amputee rehabilitation and further care, rheumatology care. So while on rehabilitation, peripheral ulcers were getting better. Unfortunately, again he developed scrotal abscess, and GU team was called for that one. And again, why he is on steroid? Again, I was questioning myself. Is it really steroids or is it really disease? So at that point, I doubted myself. So we treated it right? So this is EULAR recommendation of treatment of Behcet's disease. This highlighted in red is the decision to treat mucosa involvement and cutaneous involvement depend on the severity of the mucocutaneous manifestation. So I thought it is right decision at that time to treat the patient with systemic steroids, and most of these other the guideline only they are mentioning about Ocular disease, they are mentioning about strict guideline. All patients with ocular manifestation need systemic steroids and either TNF alphas or the others. Everything else, there is no hard evidence to say with which to treat, especially when it comes to Behcet's. So anyway, we still thought it is the right thing to do. However, we started to tapering steroids because anyway he had a poor glycemic control and scrotal abscess again. And azathioprine started once ALT is normal. So by that time we have the biopsy reports. Skin biopsy, that is again controversial. In description it says prominent vessels with fibrinoid materials in the vascular walls, and vascular lumens are occluded by fibrin and blood cells and neutrophils. The vessels also are infiltrated with, by neutrophils, but at the end, again they say no features of vasculitis. And renal biopsy, it was normal, and nephrologist suggested it probably is a minimal change disease, and renal manifestations are very rare in Behcet's disease again. He had negative immune staining as well. So what is the outcome of this patient? Patient recovered actually physically. So this is how his ulcers look now. Proteinuria actually disappeared after treatment with steroids. Currently he is off steroids only on colchicine and azathioprine. So the challenges I have faced in diagnosing and managing this patient is to differentiate what this could really be. However, if you had some kind of diagnosis in your mind, I don't think we need to label a disease before we starting a treatment to prevent complication of the disease. So if my feeling is, if we have not treated this patient with a systemic steroid at that time, he probably could have ended up with amputation of other limb as well, and he had ulcers in forearm as well, which is not responding to antibiotics or whatsoever. So my take-home messages are: clinical clues usually save lives and limbs in peripheries. If there are trainees here, I humbly ask you, just follow your clinical clues, because when you go to work in periphery, they don't have sophisticated investigation just like here. So please go with your clinical clues all the time. And I will leave you with a question: do we always need a name a disease before starting treatment in patients who have the consequences? And I would like to acknowledge patient and family members, my rheumatology team. They were big help in managing this patient, and medical team at Ampara, and Dr. Nayam, consultant nephrologist in GHS Ampara. Thank you, and I would like to take any questions you might have.
So while on adalimumab, when it was stopped, so he was getting ulcers, lower limb ulcers. So not like this, so like small ulcers, but it was the biopsy it was vasculitis, and they can have vasculitis. It's a rare presentation, but they can have vasculitic ulcers. Yeah.
I have looked when I get this biopsy report.
Yeah.
Even though the pathologist mentioned there is no features of
Yeah.
vasculitis, all the description she has mentioned.
Yes.
Those are features
Yes, fibrin, like fibrin is
Probably can't rely on all the things they have mentioned
yes.
as well, but still, because of at the from the very first look, madam, it was vasculitic ulcers to me, and
Yeah.
why I diagnosed Behcet's is because that is because of significant necrotic pathology reaction there.
Yeah, so that is very challenging because presentation is very unusual with large ulcers. But whenever there are oral or genital ulcers, always we have to
The
think of
problem is, madam,
Behcet's.
they have never asked that question.
Yes.
Even when I asked if you have oral ulcers,
Yeah.
he said yes, and that is because what patient said, ඔව් පහුගිය දවස්වල දිගටම බෙහෙත් බිව්වනේ ඒක හින්දා කට ඇතුලේ තුවාල උෂ්ණට වගේ. So that is what he mentioned.
Yeah, that
But
is
still,
very common. So
yes.
with our patient always they attribute either
Yes.
to food,
Yes.
oral ulcers.
Or-
Whenever
yes.
we ask, that's due to
Yes.
food. That's the usual answer.
Yes.
Yeah. But genital ulcers, so it's like it's
he never
very
mentioned
rare.
that,
Yeah.
and no one asked that
Yes, but
either.
it is very challenging, and other thing is renal involvement and ANA positivity. Other thing
Exactly.
is
All those things actually I have looked into the literature. All those things are there are case reports in very small prints. No major collection of the patients, but everything is there. But small print case reports actually.
Yeah.
Especially proteinuria. They have very rarely they have glomerulonephritis, and that is also not very bad glomerulonephritis. It doesn't cause significant renal impairment. I think probably this patient also had the same thing. Yes, everything is reported actually.
Yeah, so there's another patient, I forgot what I'm going to say. So there was another patient with lupus centiculum positive. So initially it was treated as antiphospholipid syndrome in dermat ward, and he was getting recurrent DVTs. That was the presentation, but leg ulcers and Raynaud's also he was said, but diagnosis is Behcet's. So he was saying lupus centiculum positivity, but responded to adalimumab.
Yeah.
And he was saying impotence is also another clinical symptom they have.
Yeah, okay.
So there's another 2 or 3 patients of Behcet's they had the impotence as well.
Yeah.
And Raynaud's also. That
yeah.
patient, particular patient, lupus centiculum
And
positive, he was getting Raynaud's from early childhood. Yeah, so there can be different presentations.
Yeah.
Yeah.
Yeah, I agree. And another thought I had while looking at these ulcers, actually I was thinking retrospectively, could this be ulcerated erythema nodosum like lesions because of the distribution of the leg, like it is over the shin and dorsum of the foot. But obviously pathology report doesn't prove that erythema nodosum has a different pathology, but this is clearly vasculitic.
Yes, our patient also getting only the lower limb ulcers, not without erythema nodosum, just ulceration, small ulcer.
Yeah. So my point is, if that was detected early pathologic reaction, that patient's the limb could have been saved.
Yes.
So that is why it is very important to go with the clinical clues.
Yeah, awareness. Other things, awareness.
Yes.
That this kind of disease exists. So we don't know. That will not. The others also will not consider the indifferential diagnosis.
Exactly.
Right. Okay. Thank you. Oh, clinical diagnosis. That is the thing. Yeah. Yeah.
Yes. If we do the pathology, it can be very tiny, madam. But this is shouting pathology, positive pathology.
Yes. So this particular patient who had vasculitis, he also had pathogenesis positivity. And so when we just asked whether there's a papule formation at the insertion of the needle, so that history was there. But oral ulcer history, only he also very reluctant to give that history. But genital ulcer also only once. Sometimes maybe only at the beginning, and later they may not get genital ulcers.
Yes.
Thank you.
Exactly. Actually, that was stopped because of the nephrologist request, madam.
Yes, from what I have learned, I don't remember where I read, and even the colleagues, for about 2 weeks, the biopsy is not going to change. So you can start and settle the patients, especially when you have, low platelets and all. You have to treat and to get it up.
Yes.
So you have about 2 weeks time to do the biopsy. So those are common pitfalls that we all encounter.
Yeah.
So Yeah.
Yeah, there was significant resistance to steroids for me, so I had to stop.
Yeah, 2 weeks, yeah.
Yes, Anushka, thank you for interesting presentation. Actually, as you mentioned, now is a multi-system disease patient, we have to think of vasculitis. As you correctly did. And once you think vascular, then exclude mimickers. You did all the investigation. Once you exclude mimickers, no need to label, then you can treat actually as you done. No need to wait till all the investigation available. Yes. Why vascular disease? Just like a building on fire. If you wait for a couple of days, you must have lost other limb as well.
Yeah,
thank you very much for your management.
Small information for the registrars also. So it is associated with the gene HLA-B51, which can be done in Arahamita blood bank. Freely they are doing from the same request form HLA-B27. There's a place to take that. Yes. And I have few patients who have positive HLA-B51.
Thank you.
Good evening to all of you, and as mentioned that now I am going to discuss about a challenging but yet interesting case of adult-onset still disease, which was a real-life experience that we came across very recently at Gaul. So we'll start with the case presentation. This was a 50-year-old male patient named Mr. S. He came to the rheumatology clinic with a complaint of on and off fever, cough, and painful swelling of the both wrist joints going on for last 1 month duration. In fact, by the time he come to our clinic, he had been treated for the same disease in 2 medical units, and he was treated as for a chest infection, and he had been received 2 courses of IV antibiotics, but there was no significant improvement of symptoms, so he ended up in our clinic. So going back to the history, we noted that the patient had been treated as for inflammatory arthritis with disease-modifying anti-rheumatic drugs from our rheumatology clinic, and that we noted that the patient had not adhered to the treatments for the last 1 year when he present with these symptoms this time. He had no significant family history or allergies. Moving on to the examination, the patient was really ill-looking, and he had high sparking fever of 102 Fahrenheit, and the respiratory system examination revealed a tachypneic patient, but peripheral oxygen saturation was all right, 97 on room air. Auscultation revealed coarse crepitations and reduced breath sounds in both lower zones, little bit asymmetrically more on the right side than left side. And the joint examination, he had tenders, swollen wrist joints, both wrist joints in fact, with reduced range of movement, which is suggestive of active synovitis. Other joint examination were clinically normal. In fact, the rest of the system examination, cardiovascular, abdominal, and central nervous system were clinically normal. Then we thought of admitting this patient for the evaluation and the management. Once the patient admitted to our ward, these are the blood investigation that we received on the first day. And you can see that he had a very high white cell reaction with predominant cell count being the neutrophils, and hemoglobin was 10 and platelet was a little bit on high side. Both ESR and CRP were elevated, and as per baseline, the liver and the creatinines were normal. And this is the chest radiograph that we took on the day of admission. You can appreciate that there are some inflammatory shadows, predominantly in the both lower zones, and there's a costopenic angle is blunted on the right side. So the X-ray radiographic features are in keeping with our clinical findings. So our impression was the patient is having a possible poorly resolving pneumonia with flare of the underlying inflammatory arthritis. So we liaised with the microbiology team and started on IV antibiotics. At the same time, we started disease-modifying anti-rheumatic drugs with NSAIDs. We started methotrexate. So the first week, the patient showed some sort of slight clinical improvement only, but it was not up to the level of expected clinical response. And on day 4, we repeated the investigation, and there was a slight improvement of the white cell count and the ESR and CRP. However, during this treatment, for the first 4 days, we couldn't localize any organism in his blood or sputum, and the sputum AFB and the TB gene expert all remained negative. So the problem started to happen after at the beginning of the second week. This is the fever chart. You can see he had during the first week he had on and off fever spikes going here and there. But you can see in the middle of the fever chart that that's the start of the second week. Patient developed clinical deterioration in terms of developing high spike in swinging fever, and his respiratory distress also became more, and the wrist joint pain also got worsened. Overall, the patient's clinical picture was going toward the deterioration. And so we did a full system examination again. What we could found new was only the bilateral cervical. The patient developed cervical lymphadenopathy on both sides. Right. So this is what happened to the investigation. So you can see the admission and the in between investigation, and particularly the day 8 is the day that he showed some kind of clinical deterioration to the first time. And you can see we did the full blood count there. There's a significant reduction of the cell counts we noted there. You can see the white cell count was 10,000 with absolute neutrophil count of 8,900, and hemoglobin more or less remained static. And the platelet also, there was a drastic drop of the platelet from 400,000 to 152,000. In addition to that, we noted that patient is having, has developed transaminitis as well in the pattern of AST more than ALT. So at that particular point, we had concerns. This could be even the, what is going on with this patient, why this patient has developed this derangement of these investigations and the clinical deterioration. So, so there were a list of differentials that we thought of this time, including the simple viral fever also can cause this kind of picture. So we just wait and watch the patient as patient was otherwise stable. So we observe the patient for the next 24 to 48 hours. As you can see, what has happened to the full blood count as the patient has developed by the next 24 hours, patient had gone into, in fact, the pancytopenic range. All the white cell count, hemoglobin and platelets has drastically dropped, and the liver functions also keep on the rise. And one interesting thing that we noted here is this rapid drop of the ESR, because you can see the ESR was 69 on day 9. By the time of day 10, the ESR has dropped drastically. This is in the context, in the background of clinical deterioration of the patient, which is little unusual. So at this particular point, one of the main concern in our patient, in this clinical context also, whether the patient is developing HLH, hemopexoric lymphohistiocytosis. So we send the investigation which are needed to other investigation which are needed to diagnose this deadly condition. So for the diagnosis, okay, there are you know that modified HLH diagnostic criteria is there, which is they are introduced in 2004. So it has two domains, molecular domain or the clinical domain. The molecular domain is based on the genetic test, which is common in children. But this kind of reactive or secondary HLH, you have to use the clinical criteria. So we try to apply this criteria to this patient on that particular day. So unfortunately, the patient fulfilled only two criteria. So patient had fever and cytopenias. The scan abdomen showed hepatomegaly, but to fulfill the criteria, you need splenomegaly, but the spleen size was normal. And some of other thing is the triglyceride also was, fasting triglyceride was 235, and still it does not score for the HLH. So the problem is now in this clinical context, the patient is worsening, developing pancytopenia, clinical deterioration, but these criteria are not fulfilling. So, but the problem is, on the other hand, if you think of if you suspect HLH, you can't wait till the criteria are fulfilled. You have to treat then and there. So this had been a problem over the time in the practice. So people have started to find solutions for this. So these are the short. So basically, this is because of there are some. So during that exercise of finding solutions for this, people have found that there are a lot of shortcomings are there in this HLH 2004 criteria. The first one is these criteria are primarily made for the pediatric population. So the using this criteria for the adult population is an ongoing debate. And other thing is the all criteria share equal importance in the diagnosis of disease. You know what that means? That means because there are 8 clinical criteria, but some of the criteria will have a high weight for the diagnosis of HLH, but some may not have. But in this criteria, what they say is if somebody is fulfilling 5 out of the 8 criteria, it will be diagnostic. But they have not really weighted these criteria. And the other thing is the cutoff values. Cutoff values also there's a problem because these cutoff values are not defined by case randomized control trials, but these cutoff values are empirically based on the experience and the observation. So, for example, if you look at this criteria, somebody is having ferritin of 600, and if the other patient, some other patient might have ferritin of 30,000. So, both of them will fulfill the criteria. So, these cutoff values, there's a problem. And the other thing is that some of the domains of this clinical criteria like natural killer cell activity, soluble CD25 receptors, and CXL9, those things are routinely not available in our practice, as you know. And in fact, in the low resource setting, sometimes the getting done of ferritin, fibrinogen, and the bone marrow also become a problem. And on the other hand, this criteria only address 8 domains, but some of the common clinical or laboratory findings which are found in HLH are missing here. So that also maybe another cause that sometimes this is not very useful. So people have in the exercise of finding some solution for this, there are 2 developments has happened in the recent past. One is the MAS 2016 score, which is designed to diagnose macrophage activation syndrome in pediatric population who are going to systemic JIA. And the other thing is the H-score. This H-score had been developed in 2014 by a French team, and they have tested this in patients with adults with possible HLH triggered by either cancer or malignancy or infection, and they have proven that it works well in adult population. So we also thought of using this H-score in our patients. So as you can see, the H-score carries 9 domains. Some of them are included in the HLH 2004 criteria as well. But in addition to that, there are some other clinical investigations that they have incorporated into this H-score as well. For example, in the HLH 2004 criteria, the AST, the liver derangement, they have not considered. But here you can see they have included the AST. And the other thing is, what they have done in addition here is that they have graded, the scoring system. Just positive or negativity is not considered, but for example, if you look at the triglycerides, so they have given a scoring system where if you have triglyceride less than 132, the score is 0, but from 132 to 352, they give a score of 44. But if it is more than 354, score is 64, something like that. So by using this criteria at the same day with the available resources, that this score scored a possibility of 80 to 88% of HLH on our index patient. So on that basis, we started treatment with IV dexamethasone. The recommended dose is 1.5 milligram per square meter, and at the same time we started oral cyclosporine as well, which is there in the guidelines as the first line treatment nowadays. Etoposide dose differed due to severe neutropenia because patient during the course of the disease absolute neutrophil count went down to 20. So we had an ongoing discussion with the oncology team as well, and after collaborative decision we deferred to give etoposide, and in addition we gave IVIG as well because of the persistent cytopenias. And meanwhile, we got the other reports as well. His serum ferritin was more than 40,000 and had significant low fibrinogen as well. And the bone marrow biopsy also revealed increased hemophagocytic activity. By the time of these investigations are available, we have halfway in the treatment course, and the patient was improving. And the other thing is for the completion of the workup, we did the viral studies which are available at Karapitiya, and everything came out to be negative, and we did proceed with the contrast CT chest and abdomen and pelvis to look for focal malignancy, which was reported as normal. So then the real problem came, why this patient went into HLH, right? So if you look at the triggers of the secondary HLH in adults, there are no many causes, like I can give 4 headings. Those are the common causes, like infections, especially the viral infections, Epstein virus, CMV, there's a list. And sometimes there are cases, the bacterial infection like Brucella and the gram-negative sepsis has caused this HLH, and there are cases reported with TB as well. And the other thing is the malignancy. Lymphomas or leukemias are known to cause this HLH in adults, and sometimes the rarely solid organ malignancies can cause this HLH. And more important thing is this rheumatological disease. So we look at the rheumatology because patient had underlying inflammatory arthritis. We had treated, the patient was on treatment. So we look at the literature. So in the literature, most of the patients with underlying rheumatologic disease has gone into HLH is caused by either systemic onset JIO, adult onset Still's disease. If I tell, it is around 90%, but other rheumatological diseases like SLE, dermatomyositis, systemic sclerosis, and mixed connective tissue diseases also can cause HLH has caused some HLH in some patients, which is there in the literature. And the other thing is the immune deficiency syndromes like congenital immune deficiency syndromes and the acquired ones, especially the patient is having acquired immune deficiency syndrome, and the post-transplant status can trigger HLH. So in our workup, looking at this list, we have satisfactorily excluded the infections here because the infective etiology was very less likely in this context because patient had been treated for 2 courses of IV antibiotics before this admission, and while on another course of antibiotics, patient went into this HLH, and the cultures all remain sterile. So and the viral studies also, all possible things we have done, all were negative, and the contrast-CT cap was negative, so there was no evidence of malignancy, and the bone marrow also revealed only the increased HLH activity, hemophagocytic activity only, but there was no evidence of malignancy in the bone marrow as well. And patient had no immunodeficiency syndrome as well. So we were thinking whether this we are treating a case of adult onset Still disease as some other inflammatory arthritis. So we had that problem, and so we went to the back of the patient's history. So this patient had initially presented to our rheumatology service in 2019. At that time, the presentation also with febrile illness with inflammatory type polyarthritis involved in the both wrist joint, knee joint, and the ankle joints. So we have investigated at that particular point the rheumatoid factor, anti-CCP antibodies, and the ANA were negative, and the patient's HLA-B27 has become positive at that particular time in 2019. So this has suggested a diagnosis of peripheral spondyloarthritis as patient is fulfilling criteria for ASA's criteria, although the joint involvement is not that typical. So during the course of the treatment, patient's systemic symptoms like the fever has settled, and the arthritis of the knee joint and the ankle joint has settled, but patient has persisted wrist joint arthritis despite sequential add-on therapy with methotrexate, sulfasalazine, and leflunomide. So when we go through the clinic notes, that what we found was that we have struggling to manage the wrist joint arthritis. So ultimately, patient being given IV infliximab because of this poor response to conventional synthetic DMARDs, to which patient responded well. And the treatment response itself and some social issues has led to defaulted treatments before this admission for last 1 year. So looking at this history, we noted although we are managing as this is peripheral spondyloarthritis, we noted some unusual features in this patient. For the first one is the initial presentation was with fever. In fact, it was a pyrexia of unknown origin. The patient had been referred from a medical unit for us where they couldn't find a diagnosis. And the joint, the onset of the joint symptoms are very short last, very acute onset. It was not going on for months when he first come to the hospital. And other thing we noted was in the investigation summary, we noted that patient had persistent neutrophil leukocytosis. And other thing is, although we are treating as for SPA, one of the hallmark features of spondyloarthritis is enthesitis. It was not there in the history up to date. And the other thing is the joint involvement also is not classical of spondyloarthritis, especially the peripheral spondyloarthritis. In peripheral spondyloarthritis, what is most common joint involvement is the inflammatory type oligoarthritis, which is asymmetrical, predominant in the lower limbs. So, but these patients, the initial presentation was the large joint arthritis, but it was a symmetrical polyarthritis. And the other thing is, we have searched in the literature whether there are any cases that HLH or macrophage activation syndrome triggered by the spondyloarthritis that we couldn't find. Every time we are going to, every time we search this, always the adult-onset disease is the thing which came on the top. So we couldn't find any recent literature for spondyloarthritis triggering HLH. So with these things, we suspected whether this patient is having adult-onset disease is going on. That we are not we have not properly addressed that problem. So let's move on to adult-onset Still's disease. So as you all know, it's a very rare systemic autoinflammatory disease. So going back to the history of Still's disease, this is first described in 1890 by Sir John Still, where he observed pediatric patients with arthritis with systemic symptoms and multi-organ involvement. So this syndrome was named in the name of Sir John Still as Still's disease, which is nowadays named as the systemic onset juvenile idiopathic arthritis. And 80 years later from that, Eric Bywaters, a British doctor, has observed similar syndrome happening in adults as well, and he has thought that this could be the adult counterpart of the Still's disease, so it was named as the adult-onset Still disease since then. So incidence-wise, it is a very rare disease, as I mentioned earlier. There's a slight female predominance over the males, and the age distribution is bimodal, like you will get one peak at 50 to 25 years of age, and the next peak 35 to 45 years of age. The etiology is unknown up to date, but there are a lot of hypotheses has developed. The most accepted one is that this is a kind of a systemic manifestation of autoinflammatory cascade of reactions due to innate immune cell activation triggered by infections and in patients with genetic susceptibility. And there are cases which have been associated with some HLA alleles and development of adult-onset disease as well. So moving on to the clinical features. Clinical features are highly variable, but there are some common features that you would tend to think of adult-onset disease. One is the fever. The typical description of fever is that it is either quotidian or double quotidian fever. That means fever spike occurs in the one of two spikes occurring daily, and it is occurring in the other day as well on the same time. And patient is really ill during the fever spikes, and in between patient is fine. And the other thing is the rash. The typical description of the rash is that someone being once in rash, but I'm afraid that with our dark complexion of our patient, some patients, the typical rash might not appear. Other thing is the arthralgia and the arthritis. The knee joint, wrist joint, ankle joint, elbow, PIP, sometimes the DIPs also can involve. This list is in the descending order. So the knee joints are the most common joint to involve, and rarely you can involve the distal interphalangeal joint as well. And one thing that we noted in the literature is the fusion of the wrist joint is a characteristic feature of adult-onset disease, especially when the disease is in the chronic articular pattern. And in addition to that, as I mentioned, there are some other multi-system features that you would expect in patient with adult-onset disease, like pharyngitis, myalgia. There's a huge list. One interesting thing that we should know is that the pulmonary involvement in adult-onset disease. There are cases reported in the literature that patients have presented with significant pulmonary involvement in terms of pleurisy, pleural effusions, and the transient pulmonary infiltrates. And there are cases of severe interstitial lung disease as well, which was rare. And sometimes the patient can go into acute respiratory distress syndrome as well when AOSD is associated with macrophage activation. So going back to our patient, that patient's one of the primary complaint was cough, which was treated as for a chest infection few times, but the symptoms were not improving, and we wonder whether this could be a pulmonary manifestation of adult onset stills here. And a few words about adult onset stills and the macrophage activation syndrome. It's a serious, the macrophage activation syndrome is a serious but a rare complication of adult onset stills. But on the other hand, if you look at the rheumatological diseases that could trigger the adult AOSD, the SOGA and the AOSD are the most common causes. This can occur at any time during the course of the Still's disease. Like sometimes there are cases, the presenting complaint is the macrophage activation in some patients. So moving on to the laboratory findings, largely these are non-specific. You would appreciate the rise in the acute phase reactants like high ESR and CRP. And the other thing is the serum ferritin. So this serum ferritin is very important marker in this adult onset stills because it correlates with the disease activity. Hence, it can be used as a marker to assess the response to treatment as well. Now there are some new data coming for glycosylated fraction of the ferritin. So that means you know that the ferritin is the iron storing protein that found in humans that present in almost all tissues. But the intracellular ferritin is non-glycosylated. In parallel to the intracellular ferritin, there's some fraction of the ferritin is secreted to the serum as well, which we measure as the serum ferritin. So these intracellular ferritin and the serum ferritin goes hand in hand in parallel. But what happens in the case of acute inflammation or acute inflammation and in certain malignancies, what happens is this the secretion of the serum ferritin becomes more into the circulation. So what happens is in the circulation, the glycosylation that cascade becomes saturated. So your glycosylated fraction of ferritin becomes less in case of severe inflammation and in case of malignancy and all. But what they have noted is, in contrast to the other causes, the adult onset Still's disease, because of the high amount of ferritin that are being secreted to circulation, this fraction almost always become less than 20. So this finding now they consider as a more specific marker for AOSD than serum ferritin. And there are some immunological markers also available, especially the IL-18, which cannot be done in routine practice. And in addition to that, the neutrophil leukocytosis and reactive thrombocytosis and elevated liver enzymes are some other laboratory findings that you will come across in AOSD. Moving on to the imaging, the plain radiographs are normal in early acute disease, but the narrowing of the radio, this is very important, the narrowing of the radiocarpal joint, intercarpal joints and the carpometacarpal joints are specific and characteristic feature of adult onset still disease. If you can remember this, the patient that we discussing, he had difficult to treat arthritis involved in the both wrist joints. So this is the radiograph of that our patient. You can appreciate that the wrist joints, the carpal bones are like ankylosed. Right. This is the pericapitate ankylosis. This is another classical radiological findings that you will come across in patients with adult onset Still's disease. You can see the bones around the capitate, especially the second and third metacarpal bone, hamate, lunate, and the trapezoid. They come closer to the capitate. In contrast to the peripheral joint spaces, the central of the ankle joint, wrist joint around the capitate has ankylose. This is the enlarged view of our index patient's wrist radiograph. You can appreciate the pericapitate ankylosis in this patient. So the diagnosis, the diagnosis is difficult because of the highly variable presentation and partly due to the absence of hallmark biochemical, histological or radiological or serology test. You can't order a single test to diagnose this adult onset testicular disease. If at all, this is a diagnosis of exclusion. So if somebody is coming with the picture of adult onset testicular disease, so the differential diagnosis is extensive. So you have to exclude all other possibilities like infections, other systemic autoimmune diseases, other rheumatological diseases, malignancy, sometimes the drug reactions as well. Interestingly, there are some cases reported in the West. Even the West, they have failed to diagnose from 1.5 years to 4 years from the symptom onset because of this variable presentation and the diagnostic difficulty. So to guide you the diagnosis, there are two criteria available nowadays. One is the Yamaguchi criteria and the Fortel criteria. Out of this, the Yamaguchi criteria is the most sensitive tool that we can use up to date. Although these criteria are designed for research purposes, these are the classification criteria. But nowadays, day-to-day practice, we tend to use these Yamaguchi criteria for the diagnosis. It has a sensitivity of 96.3 and very high specificity. So these are the criteria that you have to apply for diagnosis of AOSD in patients. If you are suspecting, it has 4 major criteria, 5 minor criteria, and the exclusion criteria. To diagnose, you have 5 or more inclusion criteria, 2 of which must be major. Right. I think this is a very important slide in my presentation. This is the patterns of adult onset testicular disease that you will come across in patients. So you can see there are four graphs there, and the y-axis is the disease activity, the x-axis is the time from the onset of the symptoms. So in these four graphs, basically we can divide this patient into 2 categories. One is the patient with predominant systemic disease activity. Other patients are the patients with predominant articular disease activity. So the red color denotes the systemic disease activity and the blue color denotes the articular disease activity. So the cohort of patients with the systemic disease activity, again you can have two groups. One is the monocyclic systemic pattern and the other one is the polycystic systemic pattern. So the monocyclic systemic pattern, the patient will come with the bout of symptoms, the systemic symptoms like fever, rash and all, and they will never get another episode in the life. So that is the monocyclic systemic. And the other, in contrast to that, the polycystic systemic, the patient will come with the recurrent episodes of AOSD flares with predominant systemic symptoms, and the patient might be in remission in between the attacks. And the other important thing that you have to appreciate in this second graph, that is the polycyclic systemic pattern, is the severity of the disease goes down as the time goes. The relapses are getting less severe as the time goes. And then moving on to the articular activity predominant group, there are again 2 types that you can identify, the monocyclic chronic articular pattern and the polycyclic chronic articular pattern. In the monocyclic chronic articular pattern, what you get is that patient comes with the flare of arthritis and the systemic symptoms, but your systemic symptoms will be resolved, but your arthritis goes on for long period of time, which can cause the deformity as well. And the other thing is the polycyclic chronic articular pattern, where the patient might come with systemic symptoms, flare of systemic symptoms and the articular disease, and the patient will get another episode of systemic symptoms in the future while patient is having persistent articular disease. Right. Okay. So this is the polycyclic chronic articular pattern. So if we try to apply these graphs to our patient, this pattern is more fitted for our patient. As you can see, the initial presentation was in 2019 with the bout of systemic symptoms and the arthritis. And afterwards, the treatment, his systemic symptoms were resolved, but his arthritis remained very difficult to manage. So that the blue area in the graph probably is the time that we were struggling to manage the inflammatory arthritis of the wrist joints. And then the index admission was again with the bout of a systemic symptom. So probably the patient is having this polycyclic tonic articular pattern of adult-onset still disease. So the management of AOSD, up to date there are no guidelines as such to manage AOSD. All the recommendations are derived from the observational case series and the clinical experiences. So the goals of therapy is to control of the symptoms and signs of inflammation, and especially the prompt recognition and treatment of the complication like macrophage activation syndrome, which is a deadly complication, and the prevention of the end-organ damage with regards to, especially with regards to the joints, and the minimization of the therapy-related adverse effects. So going back to the literature, this is a very recent article published in ACR journal, published in 2023 August. This is a combined work done by the EULA and the Pediatric Rheumatology European Society. They sat together and discussed about to come to agreement to diagnose systemic JIA and the adult-onset still disease in a common platform. So in this, they have given some definitions and some targets. So the definitions, one of the two definitions, very important two definitions are the clinically inactive disease. Clinical inactive disease is the absence of still disease related symptoms and normal ESR and CRP. So the absent symptoms with normal inflammatory markers is defined as the clinical inactive disease. And other thing is the remission. So if somebody is maintaining clinical inactive disease for 6 months, we can label them as remission. And in addition, there are some targets defined as well that you can go through. And this is another recent article published in BSR. This is about management of adult-onset still disease. This is also again the evidence and the consensus-based recommendation by the experts, given by the experts. And there are some interesting recommendations that they have given very recently. One is, first one is the NSAIDs can be given in any patient suspected of still AOSD. So you have to remember that you have to give adequate dosing. The anti-inflammatory dosing has to be given. But there are no superiority, which NSAID you should give, there's no evidence. So you can use any NSAID, but the preferred choices would be Brufen, naproxen, or the indomethacin in anti-inflammatory doses. And there are emerging evidence that IL-1 blockers like anakinra interferes less during the diagnostic workup. So you can use as a trial in terms of treatment while you are managing, while you are investigating the patient as well. So the mild disease unresponsive to NSAIDs, you can consider short course of glucocorticoids together with or without methotrexate. And severe disease, again you have to think, you have to see what domain is predominant. If the systemic symptoms are predominant, so you can use either monotherapy of glucocorticoids or combined therapy with IL-1 blocker or glucocorticoid or IL-1 blocker alone. Severe disease with predominant arthritis, if the predominant syndrome is the arthritis, you can use methotrexate with glucocorticoids or glucocorticoid combined with IL-6 or glucocorticoid plus IL-1 blocker. But you have to remember that if the joint disease is predominant, the IL-6 is preferred. That means the tocilizumab interleukin-6 blockers like tocilizumab is preferred over interleukin-1 based on the expert opinion. So if the disease is not responding to your initial treatment, you can always make a switch between the IL-1 and IL-6 inhibitors. And if it is still not responding, there's a place for TNF alpha blockers as well. Right, okay, that comes into the end of my presentation. So these are the take-home messages I would like to share with you. One is the AOSD is a very rare, multifaceted clinical, very rare disease with multifaceted clinical presentations. So always you have to suspect in appropriate clinical context to diagnose this and treat. And this could be a mimicker of other inflammatory arthritis as well as what happened in this patient. So it is very important to understand the clinical phenotypes of the disease. And there's ongoing changes and the trends in the management. So now they promote the early use of biologics rather than waiting until the complications develop. And other thing is always better review the diagnosis when you are not in comfortable zone. So then you won't not miss some of the interesting diagnosis. So I would like to thank Dr. Kelum Deshapte, Senior Consultant Rheumatologist at National Hospital Galle, and Dr. S.P. Disanayaka, Consultant Rheumatologist NH Galle, and Dr. Malini Mohatti, the Consultant Hematologist. In fact, the bone marrow of this patient was done in very real hard time amidst a trade union action, but she came out and did a bone marrow biopsy, which was a very supportive for the management of this patient. And also I would like to thank rheumatology team back in Galle and the patient and the family as well. Right, thank you.
Is there evidence for like dexamethasone then IV methylprednisolone?
For HLH, madam?
Yes.
For the management of HLH, the IV dexamethasone is preferred over all other steroids because it has the highest CNS penetration.
Okay.
For that reason, dexamethasone is preferred.
So what is this glycosylated ferritin?
Yeah, glycosylated ferritin. Yeah, the serum ferritin is the iron storing protein in our tissues. Some fraction of the serum ferritin is secreted to the serum. In serum, that amount, some fraction in the serum will be glycosylated by the addition of glucose molecules to keep it stable in the serum, right? So what in case of severe inflammation, what happens is there's a rapid secretion of ferritin into circulation. So then your glycosylated mechanism becomes saturated. So you can't, the person can't glycosylate all the amount of ferritin comes in circulation. So if you measure the glycosylated fraction in the serum in case of acute inflammation, the glycosylated fraction will be very low. That is why that they have noted that it is typically less than 20% in patient with AOSD. That's why it has come up as a new development.
Thank you.
About these treatment regimes, this is because people are looking at two ends, MAS or HLH. MAS comes from the rheumatology viewpoint. If you read, there are a lot of articles looking at MAS, right? Which gives the regimes based on methylprednisolone. But HLH comes from the other cohort. So what they do is they go with this you mentioned this HLH 2004 criteria. It has dexamethasone as the base because in malignancy-based, that is called MHLH.
Yeah.
Malignancy HLH, they have a lot of CNS involvement, so that's why they base it with dexamethasone. For rheumatological point of view, you can use methylprednisolone also as the baseline disease modifying the steroid. The thing is, if you identify early with 3 methylprednisolones and cyclosporin based regimes work well for MAS, like macrophage activation syndrome, where you enter the thing with the rheumatology point of view. Because there is a lot of it's like like I presented last time, people look at this from different angles, viewpoints. So this DEXA-based regimes, they have this etoposide starting, and then they have rigid regimes, but a lot of times you don't need etoposide. That's, yeah.
Just use methylprednisolone pulses. With that, our patients respond, patients with rheumatological diseases and macrophage activation.
Because we both, schools have different experience. That's why in my presentation, I showed it as, blind trying to understand the elephant. It's like that. People look at different angles. So methylprednisolone is good enough. With cyclosporin, it will almost always work. The problem is it might come back. If you're not vigilant, it comes back. So what you have to do is carefully monitor and take it forward, because Yes, so I have had children who, ended up in oncology unit because of this etoposide business, and then they discharged and they never followed up for systemic consent JIA, and they got a second attack and succumbed.
Other things, as you mentioned, so they can present with pleural effusions also.
Yeah.
We had one patient during pregnancy presenting with like stills, and she had significant pleural effusions. And so after treatment, so during the treatment also month, so after once remission and then later she developed macrophage activation.
All right, okay.
So you had at any point they can develop macrophage activation. Also whenever the counts are low and CRP there's high fever, the counts are low, very high CRP, you have to be suspicious of onset of macrophage
Yeah.
activation.
Yes, ma'am.